One. Please start, sir.
Good evening, doctors and eminent speakers and case presenters. This is Rajshekhar, and I am from Bayer Oncology team. As a Bayer, we strongly believe in uh, sharing science, and today we are here to understand about the or to share our updates on prostate cancer. And today I introduce Dr. Sapalta Bagmar. Dr. Sapalta Bagmar, very good evening, madam. Uh, Dr. Sapalta Bagmar, he is actually a associate professor, senior consultant in Department of Medical Oncology, Amrita Institute of Medical Science, Faridabad, Haryana. Madam, very good evening and a warm welcome for this session and today's meeting. I request you to kindly take a stage and take over from here.
Good evening, Rajshekhar, and thank you, Bayers, for giving me this opportunity. We will be discussing about metastatic HSBC. And in 2013, it's around that time when docetaxel was introduced in upfront in metastatic HSBC. Later on, in 2019, then 2017, it came with Latitude trial, with SAMPI trial, we got Abiraterone in this setting. Then in 2018, 2019, we got that enzalutamide can be used, then apalutamide can be used. And then with the aeronaut study, we are getting that darolutamide can also be used in the metastatic HSP setting. And we have three drugs when we want to use triplet regime. Then in that case, we have enzalutamide with the enzamet study in which almost like 45% patients did get triplet regime, and then Peace One trial, which actually was a practice changing for us. Then came the RSN study. So there are many options. And with Dr. Krishna Unni, we will be going through all these new heights that we have achieved in metastatic HSP setting. And he is a senior consultant at Trivandrum SK Hospital and Trivandrum. Over to you, Dr. Krishna Unni.
Thank you, madam. Thank you for the introduction. So, I'll share my screen. Is the presentation visible?
Yes, sir. It is visible, sir.
So we'll start with the new heights in metastatic HSPC care. And as you know that, so the prostate cancer, there will be the local regional and the localized prostate cancer. So if there is a biochemical recurrence, it can be initially it can be a metastatic HSPC, or if the patient has received an ADT, then it can go to a metastatic CRPC or a non-metastatic CRPC. And then there is a different population that is newly diagnosed metastatic HSPC. So once these metastatic HSPC or the primary progressive metastatic HSPC patients, once they receive ADT, they will eventually convert into metastatic CRPC, that is castration-resistant prostate cancer. And that's how the prostate cancer progress, and most of the patients of prostate cancer die due to, the majority will be having a CRPC. So how we can improve the outcome? We can improve the outcome by increasing the duration in which the patients will be in a metastatic HSPC setting, rather than getting converted into the metastatic CRPC. So the initial stampede control arm has shown that ADT, once we give ADT, the failure-free survival was around 11.2 months, and the death, the progression was, total duration was 42 months. So how can we increase this? Once we add RT, that's in the stampede arm, for patients who are having less than 4 bone mets, they had a response. And for those who were having more than or equal to 4 mets, the addition of RT has not improved the survival. Then after, then we had a lot of evidence came in. I mean, the JET2 trial, the Charter trial, the Stampede, which established docetaxel as the next addendum regimen. Then the Stampede ARM-G and the Latitude has came up with abiraterone. Then the Archies with and Enzamet with enzalutamide. Then Titan with apalutamide. And finally, now we are in a triple drug regimen phase. That is combination of three drugs. The one is the ADT plus a hormone plus darolutamide or so another addition like that. So now we are actually spoiled with a lot of choices. So how we will decide upon which regimen to give? So once we look at the data, metastatic HSPC by addition of docetaxel high volume, the improvement in overall survival was 16.8 months, while in the low volume the effect was not. It was not there. The hazard ratio was 1.04, while in high volume the hazard ratio was 0.63. So if the patient is a high volume patient in metastatic HSPC as per the Charter trial and the Stampede trial, the data was to give docetaxel plus ADT. Then Latitude trial came. The Latitude, it showed that addition of abiraterone in high-risk metastatic HSPC has shown an improvement in survival. And the PSA progression in patients who received only ADT, placebo plus ADT, it was only 7.4 months. But with the addition of abiraterone, the PSA progression itself was 33 months. So the patients who were in metastatic HSPC setting, who still stay in metastatic HSPC setting, the time has already become 4 times. So from 7.4 to 33 months. And with 5, we have to give prednisolone with abiraterone. So in metastatic HSPC setting, it's 5 mg of prednisolone. So the side effects were, as we all know, it's hypertension, hepatotoxicity, and hypokalemia were the main side effects. But there was improvement in a significant improvement in survival with addition of abiraterone. Then apalutamide. It's again apalutamide also showed there was a hazard ratio of 0.48 with PFS and 0.65 with the overall survival. And both the high volume and the low volume groups benefited from apalutamide. And enzalutamide also, the low volume group has the subgroup analysis showed low volume group has main overall survival benefit. So all the trials standalone, all these drugs have their own benefit in metastatic HSPC setting. And then came the PEACE 1 study. It was a study. Initially, it was designed as a kind of doublet regimen where the standard of care was ADT alone. But as the data for ADT plus docetaxel matured, the standard of care in the PEACE 1 trial was changed to ADT plus docetaxel. So finally, as the result came out, the PEACE 1 was a trial of triplets versus a doublet, ADT plus docetaxel plus abiraterone versus ADT plus docetaxel alone plus plus or minus radiotherapy. So the patients included were de novo M1 patients. There were high and low volume disease with good performance status. So they were randomized, and the effect was more in high volume disease. So the hazard ratio was 0.72 in the high volume disease, while for low volume disease, the median survival was not reached. It was not reported, and the hazard ratio was crossing 1. So in high volume disease, addition of a third drug has improved the survival, I mean, the outcomes. There was no benefit in adding a third drug in low volume disease. And then came our the topic of discussion today, that is the ARASEN study, which was addition of darolutamide to ADT plus docetaxel. So it was again metastatic HSPC patients, performance status, good performance status less than or equal to 1. The patients should be candidate for ADT plus docetaxel. So they were randomized to ADT plus docetaxel plus darolutamide 600 mg BD, or the other arm is ADT plus docetaxel only. And the endpoint, primary endpoint was overall survival. So in the overall survival, the overall, we see the overall population, there was a benefit in addition of darolutamide. That is, the hazard ratio was 0.68, and the benefit is seen in all subgroups. That is, high risk patients also the hazard ratio of 0.7, and in low risk patients also the hazard ratio was 0.62. So all the subgroup of patients had benefited with the addition of darolutamide to ADT plus docetaxel. The time to reach CRPC, there was a 64% risk reduction with the addition of darolutamide, and the time for a second anti-neoplastic therapy, there was a 61% reduction in the time, that is a hazard ratio of 0.39. Even pain progression also, the hazard ratio was 0.71. So all the secondary endpoints which they had studied, the darolutamide has shown a significant benefit in all those endpoints. And the patients, the patients whom the PSA response, which once we measure PSA response, in darolutamide plus ADT plus docetaxel, at any time around 67% of the patients had a good PSA response, and it was around undetectable levels. And as we told earlier, the time to PSA progression with a hazard ratio of 0.23, and the overall survival for those who doesn't have a PSA progression was significantly different with whom had a PSA, the detectable PSA at 36 weeks. And so the triplet achieved long periods of no disease response, and also there was a significant improvement in the overall survival. So when we will choose a doublet and when we will choose a triplet? So the patient should be able to, if with respect to darolutamide, if we say the first consideration is patient should be able to take docetaxel, then only we can add it as a triplet. We can go for a triplet regimen, that is ADT plus docetaxel plus darolutamide. So patient should be able to tolerate and accept docetaxel. Even the PEACE-1 study also, the patient should be able to take docetaxel. So ADT plus docetaxel plus abiraterone was the regimen there. And in adolescents, ADT plus docetaxel plus darolutamide was the regimen. So the patient should be able to tolerate docetaxel was the main concern. Then the high volume or the high risk disease, across the trials, the high volume or the high risk disease benefit from addition of triplet regimen. Addition of docetaxel, the benefit was more in high volume and high risk disease. So triplet also we tend to consider mostly in high volume and high risk disease. And if the age or life expectancy is more, then we will have to hit hard and early so that the patients will live longer. If the life expectancy is less, then there is no point in going with the triplet regimen. So, and post-AR, the ARPI progression, whether we can give docetaxel after post-ARPA progression. So in that cases also, if we can add docetaxel at the initial stage, then we can consider for a triplet regimen. Thank you. So for conclusion, for high volume or high risk patients who are able to tolerate docetaxel, and if the life expectancy which we are expecting is, if the patient is having a good life expectancy, then we can consider going for a triplet regimen with darolutamide. And the subgroup and post-hoc analysis actually had shown that even more than 70 years also, darolutamide has shown good results and good tolerability. So age is not a factor, but the life expectancy and the ability to tolerate docetaxel is the factor, and high volume and high risk disease.
Thank you, Dr. Krishnavani. Actually, how do you decide whether you want to give abiraterone or enzalutamide or darolutamide in any patient when
So,
you are deciding about the triplet regimen?
if I mean, if we are going only for doublet, then the toxicity profile is what decides which agent to be given first. Like enzalutamide has that seizure potential, abiraterone has hypertension potential. So we will assess the toxicity part and then take a call on that. If the patient is able to tolerate docetaxel, good life expectancy, high risk disease, and if the finances are okay, then we can go with a triplet regimen.
So, in my experience, actually, I felt that darolutamide is very easily tolerated. So, whenever given a triplet choice, I would like to give the darolutamide, but then because of the finances, we have to give other options as well. So, shall I present my case now?
Madam, we have another speaker.
Okay. So, Dr. Rudresh Shah. So, he is Associate Professor, Department of Medical Oncology from Kidwai Memorial Institute, Bangalore. Dr. Rudresh Shah, over to you, please. You'll be talking about
Thank
an
you.
evidence.
Thank you. 1 minute, I will share my slides. I think everybody can able to see my slides now.
Yes, sir. Yes, sir. It is should be in presenter mode. That's
Yeah.
yeah. Now it's clear.
Yeah. Thank you. At the outset, I thank Bayer giving me this opportunity. So I will be speaking about the double agent. So we started with ADT, then we went done with two agents. Then we shown that adding with docetaxel plus ADT with another androgen receptor blockade, either enzalutamide, abiraterone, or darolutamide, has shown much benefit, but maybe at the cost of some toxicity. And now we are going towards two agent drug, that is darolutamide plus ADT, whether it really make difference in the keeping the survival and avoiding the toxicity which is associated with the docetaxel. As we are aware, the most of the patients with the prostate cancer will be elderly with lot of comorbidities. So in them, docetaxel will be having side effect along with the steroids. So with keeping in this mind, so we will proceed. A minute. Yeah, the standard of care in metastatic hormone sensitive already told about charted account Stampede with Dosi plus ADT, followed by started with androgen receptor ARBs like Latitude with abiraterone and ADT, Stampede also the same. Then Archis, that is enzalutamide ADT. Then comes the Titan, that is apalutamide plus ADT. Then comes these are all the doublet. Then triplet enzamide, that is enzalutamide plus ADT plus docetaxel, and piece one, that is abiraterone ADT plus dosi. Then the just now Dr. Krishnamani presented Arsenis trial where Dara plus darolutamide plus dosi plus ADT was presented. Then now the two agent, that is only darolutamide plus ADT into in two trial, Aranot and RSEC trial. So I want to present this Aranot trial. So there is an unmet need, though there is so much of improvement in last maybe 10 to 12 years with the evolution of these ARBs from abiraterone, enzalutamide, then apalutamide, darolutamide, then docetaxel, then triple drugs. So there is a lot of improvement is there. There is no doubt, but at the same time, it may be having some little more toxicity. So with this phase 3 Arsenis trial, this DARA combined with DOSI showed that there is a beneficial effect and at the same time manageable toxicity, which leading to the approval in India in 2023. Darolutamide in combination with ADT would provide an efficacious benefit with favorable safety profile compared to by avoiding docetaxel and steroid, we are avoiding those toxicity which were associated. And most of this in this Indian patients were there in this trial. So with ARANOTE data, if it is positive and we are avoiding definitely the toxicity, then it is one of the very good doublet regime with similar efficacy with very much less toxicity. With this, the darolutamide plus ADT with docetaxel was standard of care in metastatic hormone-sensitive prostate cancer, as we seen in the Arsenis trial. And this ARANOTE was designed to evaluate whether doublet, that is DARA plus ADT versus ADT, will provide a new treatment option in the metastatic hormone-sensitive prostate cancer without using the docetaxel. So it is a phase 3 double-blind trial. The number of patients included were almost 660. The inclusion criteria, hormone-sensitive prostate, histologically proven with good PS. Stratification depending on whether there was a visceral mets were there or not. So in this group of patients randomized into 2:1 with darolutamide, which is 600 mg BD plus ADT, and placebo plus ADT. The primary endpoint was OS, and other endpoint was time to CRPC and time to PSA progression and the symptoms progression and all those things. This one is PFS. So there was crossover was allowed. If any progression in the placebo, then they can switch over to the ADT arm in the darolutamide. So you can see here most of the this thing were well matched in both the groups, demographic characteristic, with significant Asian population accounting for almost 30%. So which is very much important. And the metastasis were present. De novo was 70, recurrent was 20%. And most of the patients' visceral mets were not there. These are all most of the time is non-visceral mets, maybe bone mets. And prior local therapy was seen in almost 18 to 20% of the patient in both arms. So you can see here almost 13% of the patients were from the India. So Indian population were well represented in the trial. Most of the Western trial, the Asian populations were not included much, but in this trial it has given good share of Indian population, so that we can, whatever the result in our day-to-day clinical practice, we can apply. So you can see here the PFS with DARA plus ADT versus ADT alone. At 2 years, the PFS benefit is almost 70 versus 50. So there is almost 20% difference is there at 2 years. And it is not reached the nadir in combination, whereas in placebo plus ADT it is 25 months, and other ratio is 0.5 and p-value is significant. So definitely at 2 years, 70% of the patient have no disease progression at all compared to 50% at progression. So in this forest chart, you can see almost all the subgroup of patients got benefited with this combination. The age, the baseline PSA, the disease volume, whether it is high or low, though the volume of disease were most of the patient in this group were low volume disease, and visceral mets, if it is there or not. If there is visceral mets, though it is accounting for almost 10 to 12%, in them also this combination of therapy is worked. So in the overall survival also, you can see here not reached the median. In both this one not reached, but the time to progression to the CRPC is 13 months in placebo, which is not reached. You can see here very significantly, none of the indicator not reached, like OS, CRPC time, or time to PSA progression, or time to initiation to the subsequent therapy, and time to progression, pain progression. So all of these were not reached the median in darolutamide arm, whereas in placebo it is almost average 15 months. So all the time of primary analysis OS data are still immature. Since OS is immature, we are following it for survival. and all the remaining protocol like placebo patients offered crossover to the daratumumab, as I told initially. So the time to CRPC and time to pain, one of the important the criteria while we are treating hormone sensitive prostate cancer, the patient should not go to CRPC where the disease is very aggressive, it will be fast growing, and it is very less response to the treatment. So as much as time, if patient is there in this hormone sensitive prostate cancer, they will do well. So you can see here the time to CRPC with darolutamide plus ADT median is not reached, whereas 13.8 months in the placebo arm, and hazard ratio is 0.4 and p value is significant. Same thing, time to pain progression also. You can see here it is 30 months in placebo, not reached in the darolutamide arm. P value is significant. And also like pain and the disease progression, PSA progression also very much less in the darolutamide arm compared to the placebo arm, where hazard ratio is 0.3. In the high volume and low volume disease also, I already told in both the cases, darolutamide has done well, irrespective of the volume of the disease or depending on the whether there is a visceral disease is there or not. So subsequent life prolonging anti-cancer therapy, which is required in darolutamide is 30%, 32%, whereas it is 42% in the placebo. So there is almost 10% more people in the placebo arm received the next subsequent that is they received the chemotherapy, mainly docetaxel or any other treatment. But there is a 10% of less patient requiring the next line of treatment compared to this one. And coming to the adverse events were similar between the two groups, not much difference. The significant is grade 3 and 4 adverse events were not much difference between the two arms, and also serious adverse. So median treatment duration was almost 2 years in the darolutamide arm and 18 months in the placebo. The safety profile of Arinote was independent of PSA response and consistent with favorable tolerability as seen in ARMIS and Arsenis trial. So most of the adverse events were fatigue. Other side effects were not much problematic. It can be manageable. As I told, hypertension and vasodilation and all those things, cardiac rash, weakness, fatigue, and all those things are little bit more with the androgen receptor blockade compared to the placebo arm. So with this, in ASCO 2025, darolutamide confers positive impact in health-related quality index also. Not only the this one, as disease progression is become less, faster response, duration of response is more, pain progression less. So obviously, quality of life will be improved with this darolutamide arm. So almost all the sphere of functionality is improved with darolutamide compared to the placebo arm. So in conclusion, the darolutamide plus ADT significantly improved PFS in hormone sensitive prostate cancer, and the data for overall survival, it is still immature, but 2 years it has shown almost 20% benefit. And darolutamide is associated with deeper PSA response regardless of the baseline, and it is the first AR inhibitor which has shown meaningful delay in the pain progression and the overall functional social well-being, and also local urinary symptoms also. And of course, it is having the very good safety profile. So without giving docetaxel in some of the patients, that is triplet, where there is high risk comorbidities is there, very old frail patient, in them we can safely give the darolutamide without docetaxel. Thank you. Hello.
Yes, thank you, Dr. Rudresh.
Thank you.
Now, as Dr. Krishnavani and Dr. Rudresh have discussed about using darolutamide as a triplet regime or as a doublet regime. I'll be discussing a case in which we have used triplet regime, and this is a usual scenarios in our clinic. So now, can I share my slide? So yeah, this is the slide. Are my slides visible?
Yes, doctor. Yes, doctor. It is visible. But it's, yes, now it is in presenter mode. Thank you.
Just not moving. So he is quite a fit patient, 66-year-old, and he presented to a urologist that he is having some renal angle pain, and it was found that he's having renal stone. But in the screening evaluation, it was found total PSA was done, and it was 73.8, and followed by that the area of investigation that shifted to for the prostate cancer. Prostate biopsy was done. It was Gleason 4+4, and then medical history, he was type 2 DM. Followed by that, we did a PSMA scan, and there were almost 6 metastatic sites. So it included just a minute. Sorry. Was, in fact, infiltrating the seminal vesicle. There were multiple skeletal mets, and right from the basic occiput, then sternum, multiple ribs, multiple vertebra, first rib, and bilateral pelvic bone. So, by definition, it was a high risk, high volume disease. And there were certain suspicious lung nodules as well. You can see this, that's quite a huge volume disease, and but though he did not have any symptoms for the prostate cancer. We did an HRT, and it was not showing any hereditary genomic positivity. So by definition, as per charted trial, we can see there was more than 4 bone mets and more than 1 beyond a vertebral column or pelvis metastasis was there. And according to the latitude criteria, it was high risk disease because the Gleason score was 8 and more than 3 bone metastasis was there. And you have to have 2 or more risk factors to have a high risk disease. So it's a high volume, high risk disease, metastatic HSPC for us. So started him on docetaxel. He was a fit patient. So started him on docetaxel and darolutamide, and the slide is not moving, and edit. So orchectomy was discussed. I discussed with all the patients about all the treatment modality about GnRH agonist, antagonist, relugolix, and orchectomy, and he agreed for orchectomy, and then we gave him darolutamide docetaxel along with that. So he, though during the orchectomy and the evaluation, he started having backache, so we give palliative radiation as well to the vertebrae, and within 3 months his PSA level, it decreased, and later on it was in September that it decreased to 0.6 something. And then after that, this patient has completed 6 cycles of docetaxel. Now he is on darolutamide maintenance, and just recent this month PSA was 0.12. So he has shown a good response, and his disease is under control, and it has been almost 1.5 years of the treatment. So this is a usual thing, but there are certain things which we should discuss about in these cases. One thing, when docetaxel was over, his PSA level was around 0.6, which was like a patient whose PSA is less than 2, we consider it, well, less than 0.2, we consider is a very good response. Between 2 to 4, 0.2 to 4, we consider that this patient is having an intermediate response. And if it's 4, that means this patient is going to relapse early. So his PSA was in the intermediate risk. So I was a little bit worried, because for me this regime was the best regime that could be given to him, and even though his PSA did not drop down to less than 0.2, though right now he's doing well, and it has been almost 1.5 years. Another thing that should be taken into account is one is hereditary profile testing, another is genomic sequencing, because we were discussing in international forum about this case, and one important thing which we discussed is that we have the biopsy sample now. Once this patient progresses, it can be 2 years, 3 years down the lane, that biopsy profile will be of no use as such. And then that biopsy sample will not be of any use. And then if at all the patient progresses on bone, getting post bone biopsy becomes a difficult task, and you won't be getting any tissue for genomic sequencing. So it is a good practice that you can do a genomic sequencing upfrontly on the prostate tissue. So if it all the patient progresses, you have certain treatment options in hand. And then so heredity testing, genomic testing at the baseline, and to keep a track on the PSA level. These were the things which we discussed. Thank you. Any questions?
Thank you, doctor, and thank you, everyone. I think so. I'll just check once again if there is any questions. Doctors, any questions? If you have, you can shoot the question, or you can even type in the chat. I think so. There is no questions, doctor, and it was a wonderful presentation from everyone. And thank you so much, doctor, and thank you so much, speakers. We can close.
That time we can close it. Tech team.